I'm Liz Hay. I'm the Director of Economics and Analytics in the Strategic Reform and Planning Branch in the New South Wales Ministry of Health. And one of the key functions of our branch, besides a whole lot of capital and planning, is we look after value-based healthcare, which is a strategic priority of New South Wales Health. We also have carriage and lead of the New South Wales Health Virtual Care Strategy. So in New South Wales, value-based healthcare underpins the New South Wales Health Virtual Care Strategy. And there are 4 dimensions of value-based healthcare, and some of you are probably familiar with this. So they are the health outcomes that matter to patients, so both the clinical and the patient-reported outcome measures. The patient and carer experience of receiving care, the clinician experience of providing care, and the effectiveness and efficiency of care, and that's where the economics comes in. But we usually say that effective care is efficient care. We have recently launched and had endorsed earlier this year our virtual care strategy, and that's available on our website. The virtual care strategy covers 6 dimensions, or there's 6 key focus areas anyway, around patient interactions, remote care and monitoring, care planning and coordination, clinical collaboration and innovation, patient self-management and autonomy, and a digitally capable workforce. And that strategy has been developed collaboratively with patients, clinicians and other New South Wales health stakeholders. So I was charged with developing a monitoring and evaluation approach for the virtual care strategy. And that was quite an interesting challenge that was given to me by one of my DepSecs, because we didn't have the strategy developed at the time. So I was developing a monitoring and evaluation approach for a strategy that didn't exist. We had invested some significant funding, the New South Wales Government, into our Virtual Care Accelerator, which was to support the rapid uptake of virtual care during COVID, but that longer term strategic statewide strategy had not been developed. So our virtual care M&E plan is what we call a living document. So as the strategy has been endorsed and developed, we've been updating it. It's pretty much finalised now. So I'm just showing you the program logic there that kind of shows what our opportunity was, which is around the rapid uptake of digital technologies in response to COVID, transitioning to virtual care, bringing a new flexibility to complement existing models of care and overcome some of those time and geographical challenges while achieving similar or better outcomes, which is really, really important, particularly for our clinicians. So I'm happy to share that plan with anybody that's interested. So early on, because we do like to know what's happening in New South Wales, we commissioned NAOS to undertake an early impact analysis across those 4 dimensions of virtual care. To support this, we rapidly stood up, working with the Bureau of Health Information, a patient experience survey, and working with the university, Macquarie University, a clinician experience survey that was co-designed with clinicians. And really, clinicians were the only ones that had an input into that survey, because it was all clinicians and about their experience. So like other jurisdictions, in 2020, we experienced a significant shift from traditional to virtual care, which was accelerated by the COVID-19 pandemic, particularly in that non-admitted outpatient setting. Around 90% of patients rated the virtual care they received as very good or good, so that was pleasing. Still got a little bit to go though. There's 10% that didn't rate the care as very good or good. Virtual care was seen as a complement to traditional care with both benefits and challenges, so finding that right balance was the key, certainly not a substitute for face-to-face care. The more virtual care interactions that patients and clinicians had, the more positive they reported their experiences of virtual care. So that was a nice triangulation of those questions. Not surprisingly, given challenges with workforce, regional and rural LHDs continued to deliver the highest mix of virtual to face-to-face care. And older people increasingly adopted and were satisfied with virtual care modalities. Other groups did not show those kind of significant differences. We also undertook an early economic analysis. Virtual care at this stage is not going to solve the massive expenditures in health. Maybe in the future there will be some economic benefit from a health perspective, but at the moment it was quite a neutral outcome from an economic perspective, just when we looked through the health lens. When we looked at the broader societal impacts, though, there was an economic benefit because particularly around productivity, as patients and carers were not needing to travel for some routine outpatient consultations. Over time, we expect benefits to grow in terms of avoided hospitalisations and attendances, and particularly work for acute and chronic patients that need ongoing care. So here's some of the data in depth. So just to show that across New South Wales, and this is by LHD, the proportion of non-admitted service events delivered virtually rose from 12% to 20%. And even though that number's come down a bit now, it's still continuing to rise, and we expect around 30% to be our optimal number in the medium term anyway. This slide shows in depth some of the patient experiences of virtual care, breaks it down by age, rurality, the number of virtual care appointments that they've had, and a few other dimensions. That's available on the Bureau of Health Information website, and very pleasingly 90% of patients rated the virtual care they received as good or very good. The clinician experience was really fascinating. This was the first time we had run at scale a clinician experience survey. We were oversubscribed in terms of the number of clinicians that completed the survey, and also we followed up with focus groups because as it was the first time we've kind of run a clinician experience survey, we wanted to make sure that our interpretation of the data was validated. So a range of factors influenced clinician experiences of virtual care, and the more positive experiences were reported by clinicians who had used virtual care more frequently, so that's not really surprisingly, more experience with it, or had fewer years of professional experience. So this information, along with the patient experience information, fed into the virtual care strategy and helped shape the areas that we need to address in the future. Just coming back and wearing a ABF lens now, this work has shown some big challenges for the measurement, evaluation and other supporting factors for contemporary virtual care models. So it's very difficult to count and classify virtual care at the moment because there is no national consistent way to do this. So current data sources can and should be further developed. There's limited data on virtual modes that are not related to patient assessment and treatment interactions. This in turn limits the analysis of clinical health outcomes and any economic benefits. There's a big gap in the quality and safety measures, and so we're attempting to address some of that in our current M&E plan. And we are also looking at new data collections and strong data linkages to monitor and evaluate virtual care across the key settings. There's finding the inpatients that are benefiting from virtual care. So we have virtual ICU models, we have our RPA virtual model, we have our remote monitoring. So it is growing in that acute setting, inpatient setting very rapidly. There's no easy way to classify these patients. We are looking at working to develop an ICD code, but a national approach would be beneficial. Importantly, though, there's a lack of a nationally consistent approach to counting and classifying. And I guess one of my take-home messages or pleas to IHPA would be we really need a responsive and timely funding approach that supports this contemporary model of care. It's growing rapidly, and we can't wait for 2 to 3 years before we get the funding arrangements right. We've got lots of data in New South Wales, so we're happy to share that to inform a national approach, but we really need to act now, not wait for a long time and to support this contemporary model of care. So that's it for me. Thank you for your time.